Welcome everyone to our final session of the series on rheumatology. Your host tonight is Dr. Nayan Kothari, who's the chair of the Department of Medicine and chief academic officer at St. Peter's University Hospital, and he also serves as the program director there. He has no financial or non-financial conflicts of interest relevant to this activity. And this activity has been granted a total of 6 AMA PRA Category 1 credits. Also, successful completion of this activity will allow you to earn up to 6 MOC points. To get credit, you will go to this link and complete the module and the post-test. This will all be emailed to you after the session. And Dr. Kothari, it's all yours. Oh, sorry. Please feel free to put questions in the chat, and we will make sure that Dr. Kothari knows that they're there and can answer them.
Did we stop here last time?
We stopped right before this last time.
We were discussing dermatomyositis and polymyositis. So just a few words about malignancy and polymyositis, dermatomyositis. Malignancy may precede, occur concurrently, or follow the muscle disease. Mostly it follows. Typically occurs in older patients and are more common in dermatomyositis than polymyositis. This is an important point. The evaluation of malignancy is warranted in older people with dermatomyositis, particularly if they're refractory to treatment. And this happens in the boards all the time. How much workup do you do? Age and gender specific workup is all that is necessary. There is no point in doing PET scans and body scans, etc. So if they need a mammogram, do a mammogram. They need a colonoscopy, do a colonoscopy, but nothing more than that, unless your clinical suspicion for a particular thing is high. Next slide, please. A 26-year-old woman diagnosed with dermatomyositis 1 year ago is evaluated for a recurrence of muscle weakness, particularly in the lower limbs, of 3 months duration. At the time of diagnosis, her CK was 3,580, and finding on the EMG and muscle biopsy were consistent with dermatomyositis. She was treated with high-dose prednisone, which is the treatment, 1 milligram of prednisone per kilogram, and was associated with resolution of the rash and recovery of her strength and normalizing the CK. Her rash has not recurred. Next slide, please. Physical examination is remarkable only for isolated lower limb weakness, proximal muscle weakness, and CK now is 165. Remember, it was 3,000 plus. Which of the following is the most likely cause for the patient's recurrent weakness? Please answer this question. A, dermatomyositis. B, inclusion body myositis. C, corticosteroid-induced myopathy. D, hypothyroidism. And E, disuse atrophy. Please answer. Okay, everyone got the answer. That is a corticosteroid-induced myopathy. This happens anytime we use high-dose prednisone. And sometimes it is difficult to distinguish between the original disease of dermatomyositis and the steroid-induced myopathy. The key is in the CK. In the dermatomyositis, CK is almost always elevated. In steroid-induced myopathy, CK is not elevated anytime. So that is the difference. And one has to keep in mind because one can easily forget and give the wrong treatment. Next slide, please. So summary of dermatomyositis is, it is the only itis with minimal pain. When I ask my residents what is the chief complaint in dermatomyositis, invariably they will say muscle pain. It is not the pain, it's the weakness is the chief complaint. And it is proximal because that's where most muscles are. Your thigh muscles, your deltoids, triceps, etc. In neuropathy, on the contrary, the symptoms are distal because it depends upon the length of the axon. The treatment for dermatopolymyositis is corticosteroids, and if that doesn't work or that gives you a lot of side effects, then you can use immunosuppressant, including methotrexate and now rituximab. Remember steroid myopathy, as we just discussed. Do not do a malignant workup, excessive amount of testing to look for malignancy. Only do what is gender and age specific test. Next slide, please. ANA is present in 80% of patients with dermatopolymyositis. Remember that AST and ALT are not liver specific, and in a dermatopolymyositis, CK would be elevated, but AST and ALT also would be elevated, and therefore it can confuse with the presence of liver disease. The presence of Gottron's papules and heliotropic rash is virtually diagnostic of dermatomyositis. You still do a CK, but it's a clinical diagnosis, just like herpes zoster. You look at it and you have a diagnosis. Next slide, please. Serum, I told you serum AST, ALT may mimic liver disease. If myositis is unresponsive to treatment, that's prednisone, consider a diagnosis of inclusion body myositis, but the patient is different. In inclusion body myositis, to recap, is an elderly male, typically, is very slowly progressive. There is an asymmetric weakness between left and the right, between the flexors and the extensors, and there is an element of neuropathy, so distal muscles are involved. And it absolutely does not respond to any treatment. Next slide, please. Amyloidosis. There are three kinds of amyloidosis we must know. One is AL, other is AA, and the third is dialysis-related amyloidosis. So let's talk about AL. L stands for light chain. And the manifestations include nephrotic syndrome with enlarged kidneys, restrictive cardiomyopathy, carpal tunnel syndrome. Almost in all amyloidosis, carpal tunnel may be involved. Periarticular amyloid deposits, and that's what causes shoulder pads and joint effusions. And one of the hematological manifestations of AL is acquired factor 10 deficiency. So the case may be a patient with amyloidosis comes with bleeding and nothing works. Think about acquired factor X, the factor 10 deficiency. Amyloid fibrils somehow attach to the factor 10 and lower the numbers. Extremely difficult to treat, irrespective of what you give them. Next slide, please. Here is a patient. We have several physical findings. Number one, there's ecchymosis. Remember, amyloid tissues bleed, so you don't do liver and kidney biopsies on amyloid patients. Look at his tongue. He cannot accommodate his tongue. There's a macroglossia. This could be hypothyroidism, or this could be acromegaly, but I think in this context, it is amyloidosis. And if you look at his shoulders, even though he is cachectic, look at his supraclavicular fossa. He has lost a lot of weight, but his shoulders are enlarged. And that is, they are called shoulder pads, and there is a periarticular deposits of amyloid. Next slide, please. The A amyloid, A stands for amyloid A protein. The commonest cause in US would be rheumatoid arthritis. The commonest cause in Turkey would be familial Mediterranean fever. The commonest cause in Asia would be leprosy, tuberculosis, and osteomyelitis. Osteomyelitis can occur here too. In a young fellow, 20 years old, who is a drug addict, skin popping, that is another cause for amyloidosis because it causes chronic inflammation. It presents as nephrotic syndrome, and cardiomyopathy is extremely rare. If you have a cardiomyopathy and if you suspect amyloid, it is probably not AA or secondary amyloidosis. You have to think about AL amyloidosis. Next slide, please. This comes up in the exam all the time. Beta-2 microglobulin associated amyloidosis. It is seen in patients on dialysis. The beta-2 microglobulin is an immune product and is excreted by the kidneys. Normally, we all have it. But if you are a patient with a renal failure, and if you're not on dialysis, you will not get beta-2 amyloidosis because you will die. The people who need dialysis but cannot get dialysis. So in many countries where dialysis is not available, they do not see this condition. But in US and other Western countries, dialysis is available, so these people live longer, 10, 15 years after their renal failure. So the beta-2 microglobulin accumulates mostly under the carpal tunnel, and they get carpal tunnel syndrome. So the typical story would be a patient is on dialysis for 5 to 10 years, develop numbness and tingling of both hands. What's the diagnosis? It's amyloidosis. And the amyloid is a beta-2 microglobulin. It can also extend into subchondral bone erosions, and it may cause a destructive arthropathy. And if it affects many joints, it may look like rheumatoid arthritis. But I think if they ask you that, they will give you the appropriate language. Next slide, please. A 42-year-old woman has 3-month history of pain and non-dependent swelling of both ankles, low-grade intermittent fever, fatigue, and 10 pounds of weight loss. So there is something systemic going on. She has a painful bruises of the lower extremities that last several weeks and then resolve. On physical exam, she has 99.8, a tender, dark red subcutaneous nodule measuring 1 centimeter is present on the right lateral lower leg. There are very few things happen on the lower leg. Both ankles are erythematous and show marked soft tissue swelling that extends to the distal lower extremities. So it's not limited to the joint. Note that. Motion of the ankle causes moderate pain. Remainder of the joint examination and the general physical examination is normal. They're not asking you to diagnose it. They're asking you what would you do next. CT scan of the chest, radiographs of the ankles, radiographs of the chest, and a bone scan. Please answer. Note that the wording is what will you do next? I think this question requires some discussion. The correct answer is X-ray of the chest, not CT scan, and I'll tell you why in a minute. X-ray of the ankles would not give you any information than you already have. Bone scan is not the correct answer because there is nothing wrong with bone. Bone scan picks up osteoblastic activity, so it will be okay if you suspect osteoblastic metastasis or hypertrophic osteoarthropathy, but that is not the case here. So let's go to the next slide. These are the painful bruises this woman had, and these are erythema nodosum. Erythema nodosum can occur as a result of number of conditions: antibiotics, streptococcal infections, histoplasmosis, coccidiomycosis, etc., but also sarcoidosis. Birth control pill can do that, pregnancy can do that. So it's a wide differential diagnosis. Next slide, please. And this is hilar adenopathy. You don't need a CAT scan to diagnose hilar adenopathy. Therefore, the CAT scan is not the correct answer. Now, remember they ask you, what is the test you do next? So CAT scan is not a wrong answer, but you are not going to do it next. You're going to do the chest X-ray first, look at hilar adenopathy. If you're concerned about parenchymal involvement, then you might do a CAT scan. But the next question makes it chest X-ray as the correct answer. Next slide, please. So sarcoid arthropathy has 2 different patterns, early and late. The early one is called Lofgren syndrome, Lofgren. Lofgren was an ophthalmologist, and it causes acute arthritis, periarthritis of the ankles. We already talked about periarthritis in amyloidosis. This is another condition which causes periarthritis. That means that the synovium is not involved, but the big erythema nodosum is wrapping around the ankles. That's what it is. And it's associated with erythema nodosum and hilar adenopathy. So it's a triad. Periarthritis of the, why it affects the ankles, we don't know. Why erythema nodosum affects the legs, we don't know, but that's what it is. The good thing to remember about this condition is an excellent prognosis. It goes away in 4 to 6 weeks. And very rarely, you may want to give a short course of steroids. You do not need to do a biopsy to demonstrate sarcoid granulomas. Lofgren syndrome is highly specific for sarcoidosis, therefore a tissue biopsy is not necessary. There are many conditions, as a fact, in medicine where you do not do any more testing. Classic example is herpes zoster. You don't do any test. This is another one. Next slide, please. A 50-year-old male is evaluated because of pain in the right groin, lower back, and hands. So it's diffuse. The groin pain is worse when he walks. The physical examination, internal rotation of the right hip elicits pain. So they tell you several times that he has a hip problem. Now, hip is, for you and me, the hip is the acetabular joint. For lay people, the hip is the gluteal region. So make sure that you don't mistake one for the other. This person has the true acetabular joint involvement. And he also has lower back pain and hands. The second and the third MCP, metacarpophalangeal joints, are swollen and tender. So now we know why he has a hand pain. X-ray shows severe osteoarthritis of the right hip. He's 50 years old. That is a little too early to develop severe osteoarthritis. Besides, he has MCP joint involvement. Which of the following is the best test to confirm the diagnosis? Mind you, to confirm the diagnosis. Rheumatoid factor, HLA-B27, serum iron and iron binding capacity, fasting plasma glucose, serum uric acid. Please answer. Okay, the correct answer is serum iron and iron binding capacity, and I'll tell you why. Rheumatoid factor never confirms anything. You know that. So the word, you have to read the stem of the question. This is called the stem, the last sentence before the answers. Rheumatoid factor never confirms anything. It may assist you in diagnosis, but not. We talked about HLA-B27. I had made a statement that HLA-B27 is not a test, should not be done. One of our participants, Dr. Pablo, told me that that is not entirely correct. HLA-B27 has a place in when the diagnosis is in doubt. There is nothing to suggest that this person has spondyloarthritis. They have not given you the picture. His age is somewhat more advanced. Serum uric acid, even if you think it is gout, serum uric acid is never the answer, because during acute attack of gout, this is not acute, but as when we discuss gout, we will bring this point that serum uric acid actually drops during the attack of gout. So that won't confirm the diagnosis. Confirmation of gout would be microscopic examination of the fluid and demonstrating the crystals. Fasting plasma glucose can help diagnose because this is hemochromatosis. Hemochromatosis might give you pancreatic involvement and high sugar, but it will not confirm the diagnosis. So read the question very carefully. The only thing which might confirm would be serum iron and iron binding capacity. Next slide, please. So this is hemochromatosis in one slide. Here is a man who has a little tanning of his skin. It looks like a nice tan. And he himself may not have noticed the change in his complexion because it takes years. The other thing to remember about skin pigmentation, that the nature of pigment is not melanin, not iron, but it is melanin. Every time I ask this question to students, they always tell me it is iron. It is not. There may be some iron in the skin, but it's actually melanin, and it's driven by the pituitary. Because remember, ACTH has a portion of the ACTH, which is a melanocyte stimulating hormone. So it is a central phenomenon. Hemochromatosis causes arthritis, and I will talk about this, cardiomyopathy. Diabetes, that's why, and the skin pigmentation, that's why it's called bronze diabetes, and also hypogonadism, which is also central via the pituitary. Though you can demonstrate iron deposits into the testes, but the actual hypogonadism occurs on account of central phenomena. Next slide, please. So hemochromatosis causes arthritis, and this is very important for you to remember. The best way I can explain is it causes osteoarthritis in unusual places. It can cause chondrocalcinosis and pseudogout, but that is not the main type. Osteoarthritis, remember in the hands, the osteoarthritis occurs in the distal joints, we call them Haberden's nodes, in the proximal joints, we call them Bouchard's nodes, but almost never occurs in the metacarpophalangeal joints. Hemochromatosis, for some reason, affects the metacarpophalangeal joints. And if you close the fist, the second and third joint will not bend. And the cartoon on your upper right is the so-called iron fist sign. And it's pretty practical. You can pick it up. So if you see osteoarthritis in MCP joints, which you should not have osteoarthritis, it is hemochromatosis unless proven otherwise. The same thing holds good for osteoarthritis of the ankles. Ankles do not get osteoarthritis. Hips do, knees do, feet do, but not ankles. So osteoarthritis in unusual or odd places would be hemochromatosis. And the test you do, not the genetic test first, but iron and iron binding capacity. And the treatment of hemochromatosis is phlebotomy. And please learn the math, how much phlebotomy you need to do to remove enough iron. Incidentally, phlebotomy will not change the course of the arthritis. The picture on the left is chondrocalcinosis. It's a calcification of the cartilage, which can be seen in number of conditions. We will talk about that in a few minutes. Next slide, please. Now we are going to talk about the bread and butter of rheumatology, the bread and butter of medicine. All of us see these people. Osteoarthritis, otherwise called degenerative joint disease. It is not systemic. It is slowly progressive. I think all of you know it occurs in weight-bearing joints, distal interphalangeal joint, proximal interphalangeal joint. The first carpometacarpal joint at the base of your thumb. And don't forget the acromioclavicular joint at the top of the shoulder. And as I said earlier, it spares the metacarpophalangeal joint. So if you see osteoarthritis in metacarpophalangeal joint, it is something else. There may be morning stiffness less than 30 minutes. A lot of older people are a little stiff in the morning. That's why they added this. But if it is more than 30 minutes, 40 minutes, an hour, it is inflammation. And the physical finding is bony swelling in contrast to rheumatoid, where there is soft tissue swelling, and crepitus. Crepitus alone without the pain does not have any significance. A lot of people come to me and say, my joints crack. And first question I ask, do they hurt? No, so then nothing to worry about. Next slide, please. A 26-year-old woman has gradual onset of dull ache over the anterior surface of both knees, right more than the left. But note that it is anterior surface. Pain occurs when walking up or down the stairs or squatting. Is worse by prolonged sitting and relieved after a brief walking. If anything gets worse in musculoskeletal system on sitting, is inflammation. Anything gets better on activity, it is not inflammation. Patient is physically active and runs approximately 15 miles every week, but has stopped running because of pain. Examination of the knees show no effusions or instability. Ballotment of the patella disclose mild tenderness. Ballotment is a sharp thrust onto the patella while the knee is extended, and X-ray of the knees are normal. Next slide, please. Which of the following is the most appropriate management? Management could be diagnosis or could be treatment. Naproxen, arthroscopy, rest, quadriceps muscle strengthening exercises, and hamstring stretching, injection of the knee with corticosteroid, and resumption of normal activity. Please answer. Okay, I think most of you got this right. I think those of you said naproxen is probably a sort of a correct answer, but look at the stem. Which of the following is the most appropriate? So yeah, I think naproxen would be a viable option, but it is not the most appropriate. I'm glad nobody said arthroscopy, but some of you want to resume normal activity. This is an overuse syndrome. And this is remember the knee joint actually has 3 joints: the medial compartment, the lateral compartment, and the patellofemoral joint. This is, and the lady is young, 26-year-old runner. You don't get osteoarthritis at that age, but she has a patellofemoral involvement with overuse. So you need to ask her to back off in terms of running. Remember that the knee joint is protected by the quadriceps muscles. If your quadriceps are weak, your knee will collapse. So whenever you examine a patient with a knee problem, any knee problem, either osteoarthritis, rheumatoid arthritis, ligamentous injury, check their quads. And if the quads are weak, have them do quads exercise. The physical therapists are very good at it. And also do some hamstring stretching. It will take time. They will have to have patience. You may, after giving C, you may add an naproxen for a few days. And there is absolutely no indication to give an intra-articular steroid because this is not a real intra-articular problem. Next slide, please. This is a classic osteoarthritis of the, I don't know whether, yes, I can show the pointer. This is the evidence notes. The only condition which gives you DIP involvement, distal interphalangeal involvement, is psoriatic arthritis. We talked about this. Or infection, one of these evidence nodes can get infected. And if you look at this finger, it is the proximal interphalangeal joint, which is also called Bouchard's nodes. It's not here, and not here, but here and here. This is classic osteoarthritis. The interesting thing about osteoarthritis is it transmitted from grandmother to mother to daughter. The males in the family escape it most of the time. That's one thing to remember. The second thing to remember, they may look bad cosmetically, but typically they don't give you any problems. They occasionally hurt, but the cosmetic problem is there and there's nothing much you can do. Next slide, please. This is an X-ray of the first carpo-metacarpal joint, which is at the base of the thumb. And osteoarthritis of that joint is extremely painful. Remember that in your hand, you can cut away 3 fingers and leave your thumb and 1 finger and you can function. You can pinch, you can grasp with 1 finger. You don't need all 4. But if anything goes wrong with the thumb, there's nothing you can do with 4 fingers. You cannot grasp, you cannot pinch, you cannot do anything. So anytime you have a patient with an involvement of the thumb, there are only 2 conditions which would do that. One is osteoarthritis of the base of the thumb, the carpo-metacarpal joint, as you can see. And the second is decurvane tenosynovitis. I'm coming to that a little later when I do office rheumatology. So, and how to distinguish one from the other. No effective treatment. And when we do questions, I think we will come to an answer for that. Next slide, please. So therapy of osteoarthritis, the American College of Rheumatology, until mix-up 16, kept on hammering that the treatment is Tylenol. It's not. Finally, they have given up Tylenol. So do not waste your time on Tylenol. Low-dose NSAIDs, if not contraindicated, are fine. Tramadol only if, remember, tramadol is a weak opioid, so you don't want to commit somebody to anything like an opioid. But the move now is topical NSAIDs. And I think if you watch television for 10 minutes, you will see the advertisements on Voltaren. It's effective if it's a small area. Occasionally, intra-articular steroids and hyaluronic acid can be given, but the benefits are very short-lasting. I would not recommend that. As I said earlier, the most important thing you can do for osteoarthritis of the knee is to make the quadriceps strong. Do not do arthroscopic lavage. The orthopedic surgeons, not now, but in the past, were very vigorous about putting an arthroscope and do lavage, what I call laundry. Doesn't work. Absolutely unnecessary, exposing patients to danger. There are no lab tests necessary to diagnose osteoarthritis unless there is a comorbid condition for which you know you need something. Weight loss can lower the risk of developing osteoarthritis. One of the questions they have been asking, what would you do to lower the incidence of gout, rheumatoid arthritis, and osteoarthritis? We discussed this in rheumatoid. Smoking cessation prevents development of rheumatoid. Weight loss prevents the development of osteoarthritis. And when we talk about gout, we'll discuss the other thing. I don't know whether I have it on the slide, but one management I left out, and that is the use of a cane. American culture in general, patients will not use a cane. They will not use hearing aid and they will not use a cane. At least most of my patients refuse. They may be tone deaf, but will not use a hearing aid. They may be limping all the time, but they will not use a cane. Learn how to use a cane. The cane should be used on the opposite side. So if you have osteoarthritis and pain on your right side, your cane should be on the left side. And the cane should have a proper length so that your elbow remains at about 45 degrees flexion. It should not be touching your chest and it should not be straight. And make sure that the length of the cane is proper, and make sure also that the bottom of the cane, there should be a nice rubber padding. And this rubber padding goes away once after the usage, and patient might fall if they are on a wet surface. So if they come in your office with a cane, check the cane. Examination, musculoskeletal examination is never complete unless you check the shoes, the wear and tear, and unless you check the cane. Next slide, please. A 73-year-old woman has osteoarthritis involving multiple joints, DIP, base of thumbs, knees, cervical, and lumbosacral spine, widespread. She has tried over-the-counter analgesics, physical therapy, intra-articular steroids, intra-articular hyaluronic acid, over-the-counter NSAIDs. She was recently diagnosed with a peptic ulcer disease. She has coronary artery disease, hypertension, diabetes, and medications are enalapril, carvedilol, metformin, torvastatin, pantoprazole, and low-dose aspirin. A lot of stuff. And she has a diffuse osteoarthritis, multiple joints. Which of the following is the most appropriate treatment? Gabapentin, ibuprofen, topical capsaicin, duloxetine, oxycodone. Please answer. If you use I think many of you answered capsaicin. If you use capsaicin on a lady, you will kill her. Just to look at the surface area, you need to apply capsaicin. That's impractical and would be toxic. Gabapentin works for neuropathies, not for arthropathies. She has a peptic ulcer disease, she has hypertension, diabetes, so NSAIDs are out. Oxycodone, there is a general rule in musculoskeletal diseases, opioids are absolutely contraindicated. We use them, but I think for practical purposes, do not use opioids. The correct answer is duloxetine, which is an SNRI, and it has some mechanism by which it reduces diffuse pain. Whether it's articular, it's fibromyalgia, it's something else, but duloxetine is the correct answer. But please don't use capsaicin unless you have a very small area. Next slide, please. A 75-year-old woman is seen for pain in the finger joints. She reports pain at the base of her thumbs. She has difficulty opening jars. Current medications are acetaminophen 2 to 3 grams daily and quinapril 20 milligrams for hypertension. Blood pressure is 162/88, which is high. Heart rate is 70, BMI is 30. Physical examination abnormalities are found only in musculoskeletal system. Several DIP of her hands show bony enlargement without tenderness. The first carpometacarpal joint of both hands are tender. The knees extend fully with crepitus. If they don't hurt, it is not an issue. A CBC and chemistry are normal. Next slide, please. Which of the following is the treatment next? Naproxen, hydroxychloroquine, tramadol, diclofenac gel, physical therapy. Okay, I think many of you got this. The correct answer is diclofenac gel. Well, first of all, this is a very limited area, 2 carpometacarpal joints, which is 1 square inch on each side. So it's practical to apply even capsaicin if you want to. But capsaicin is not the option. You don't want to give naproxen. He already has uncontrolled hypertension. Hydroxychloroquine has no place in osteoarthritis. It does work in rheumatoid and lupus. You don't want to give opioids under any circumstances unless you have to. So tramadol is out. And what will physical therapy do? You know, I think in the general rule, if you don't know what to do, give physical therapy. That's how I treat physical therapy. There's absolutely no indication for physical therapy. The correct answer is diclofenac, local. Next slide, please. Okay, we are now going to crystals. There are 3 kinds of crystals we should know. One is, and there's a lot of confusion with names. So I want to spend little time on this slide. One is hydroxyapatite, note the spelling APATITE, which is also called BCP, basic calcium phosphate. There is no pyro in this. Note, it is not basic calcium pyrophosphate. It is basic calcium phosphate, otherwise called hydroxyapatite. Everyone knows about uric acid. The third one is calcium pyrophosphate dihydrate, CPPD. There is a pyro there. I find a lot of people confuse BCP for CPPD. They're totally different crystals. The picture on the left is uric acid crystals. We'll talk a little more. Picture in the middle is a look at the symphysis pubis, and it is all calcium there. There's a calcification. That is a CPPD crystal. And this is amorphous. There is no crystallization here. And that is the BCP crystal. BCP crystal is amorphous. It cannot change the polarized light. These 2 crystals have ability to bend the polarized light. Next slide, please. So let's talk about hydroxyapatite and BCP crystals. It has a various expressions depending upon who the host is. BCP is the primary mineral in bone and teeth. So there are tons of BCP in your body. But it causes disease in certain individuals. For example, it causes Milwaukee shoulder knee syndrome. We'll talk about this. It can cause recurrent hemorrhagic effusions in the elderly, which is very similar to Milwaukee shoulder knee syndrome. It can cause destructive arthropathy, which is also a feature of Milwaukee shoulder. And most common for us, tendonitis and bursitis. What you see in your office is shoulder tendonitis. That is BCP disease. And why would it cause tendonitis in one person and a Milwaukee shoulder in another person? We don't know. It's very similar to parvo B19. In children, it causes erythema infectiosum. But in the mother, it would cause arthritis like rheumatoid. So the host determines the expression of the disease. Next slide, please. A 73-year-old woman has 2-year history of pain in the right shoulder and both knees, associated with progressively decreasing range of motion and significant disability. Physical exam discloses a frail, elderly woman. She's 73, but she's frail. Motion of the right shoulder is marked decrease in all planes. Remember, the shoulder is the most mobile joint in the body. Abduction, adduction, flexion, extension, internal rotation, external rotation, and circumduction. There is no joint which moves as much as the shoulder. The next joint which moves the most is the carpometacarpal joint. The right shoulder appears larger than the left and has a large effusion. So not only the shoulder has a restrictive motion in every plane, what does that mean? If every plane is involved, it has to be a glenohumeral joint. Because shoulder is a complicated joint. It's a glenohumeral, acromioclavicular, and thoracoscapular. Because shoulder moves all those three joints. But because it is all planes are affected, it has to be glenohumeral. X-ray shows migration of the humeral head superiorly. So the humeral head is moving up towards the acromion with a destructive erosive changes in the humeral head and both knees. So this is a destructive arthropathy. So why is the humeral head moving up? So the question is, why is the humeral head not moving up in you and me? What keeps it there? Remember your humerus anatomy, the fossa in which the humerus, head of the humerus sits, is a very shallow fossa. And how does the humeral head then stay in? Is unlike acetabulum. Acetabulum is a deep cup. So the femoral head gets into it and doesn't come out. But it is not so for shoulder. The shoulder, the humeral head sits on a very shallow surface of the scapula. So something must keep it there, and that is the rotator cuff. The rotator cuff keeps the humeral head in place. So when you see that humeral head is moving up, it automatically means that the rotator cuff is torn. That's what it means. Radiograph shows calcification of the soft tissue surrounding the joint capsules of the shoulder. Arthrocentesis of the right shoulder yields a thick, chalky fluid. So there are crystals. Polarized light microscopy of the fluid shows abundant, dense, amorphous material with no birefringent crystals. That means it is unable to move the polarized light. There are certain crystals will bend the polarized light. This one doesn't, and it is amorphous. Next slide, please. Which of the following is the most likely diagnosis? This should be 100% answer. Frozen shoulder, basic calcium phosphate crystal disease, Milwaukee shoulder, calcium pyrophosphate dihydrate deposit disease, pseudo gout, trophaceous gout, reflex sympathetic dystrophy. Please answer. Okay, we got 100%. I would have been very upset if we did not get that. Huh? Somebody is still confusing calcium pyrophosphate. Okay, the correct answer is what all of you got, basic calcium pyrophosphate, the BCP deposit disease. This is the classic Milwaukee shoulder knee syndrome. Next slide, please. This is the lady we are talking about. You can say from the picture that she is a frail older woman. You can see that the left shoulder has a big shoulder pad. Now, I told you a few minutes ago, the shoulder pads in amyloidosis. What's the difference? In amyloidosis, it's bilateral. In Milwaukee shoulder, it's typically unilateral. And if you look at the X-ray, there is no glenohumeral space. It is all gone. And there is a large area of destruction of the humerus. This is classic Milwaukee shoulder. And of course, there will be a knee problem simultaneously. Next slide, please. So Milwaukee shoulder knee syndrome typically affects frail elderly women. Why? We don't know. It's a chronic shoulder pain, unilateral, with a large non-inflammatory effusion, as in that's why it gives you the big shoulder pad. And if you aspirate, you will get a milky little liquid. And the rotator cuff tear tends to upward migration of the humeral head. So whenever the radiologist says that the humeral head is going upwards, think about tear of the rotator cuff. There is no good treatment for this condition. Next slide, please. So this is destructive shoulder. And if you go next slide, let me see a couple of slides. Okay, please go back. Okay. Milwaukee shoulder is a destructive arthropathy, but there are other destructive arthropathies, and I think all of us know the Charcot joint or the neuropathic arthropathy. It's a destructive arthritis secondary to denervation. Usually occurs in weight-bearing joints, usually, but not always. There's a common misconception that Charcot joint is a painless joint. That's not true. It is painful, but the pain is much less than expected. That's the point. You have a destroyed joint on X-ray or clinically, but the patient is not really complaining a lot. Traditionally, when Charcot described this, it was knee joint, which was Charcot, and that was due to syphilis, tabes dorsalis. Today, the commonest cause of Charcot is diabetic neuropathy or any neuropathy. And if you have a Charcot of the shoulder, it is syringomyelia. The joint replacement is not the treatment for Charcot joint, because if you put a new joint, it will loosen very quickly and will fail. Next slide, please. This is the representation of Charcot. On the picture on the left is Charcot due to syringomyelia. There is no joint there, it's completely destroyed. The picture on the right, on the top, is the Charcot of the knee. You can see the knees are completely destroyed, the fragments of bones. And what you might see on your wards tomorrow would be Charcot of the feet. Most common mistake made of Charcot of the feet is osteomyelitis. This is the reason why biopsy is necessary to diagnose osteomyelitis. So don't forget that, because Charcot, I have known cases where patients have been given recurrent courses of 6 weeks antibiotics because Charcot was missed and it was misdiagnosed as infection. Next slide, please. I told you the BCP crystal causes also calcific periarthritis, which we see every day almost in our clinics. It is also a BCP deposit disease, calcium appetite, or BCP. The most important point I want to convey is that it is self-limited. So anytime anything is self-limited, you don't give much treatment. I told you about Lofgren syndrome of acute sarcoidosis is self-limited, so you don't want to give too much treatment. When we did vasculitis, I told you about Hanoch-Schönlein purpura. It's self-limited, so don't give them a lot of steroids. This is another one. Patient comes with a shoulder pain, acute or subacute, and swelling around the tendencies of the diarthrodial joint, which is the shoulder joint. Shoulder is the most common site, and there may be homogeneous calcific densities adjacent to the joint during the acute phase. During the acute phase, mind the words. Next slide, please. As I said earlier, the crystals are not birefringent. They do not bend the polarized light. The important thing for us to remember, complete resolution occurs after several weeks. So the natural history of the disease is acute onset. 6 weeks later, the calcium goes away. Now, typically what happens, patient comes with complaining about pain, you diagnose subdeltoid, subacromial bursitis, you do an X-ray, you don't have to, but you do an X-ray, you see calcium. Patient is not better, in spite of the fact that you gave injection, you send him to an orthopedic surgeon. The orthopedist looks at the picture, shows the patient the chunk of calcium, which I'll show you in a minute, and says, oh, you got a lot of calcium there, I got to take it out. And the next thing you know, he goes for surgery, he does something, patient is getting physical therapy for 3 months. Please prevent that. It responds to NSAIDs and local corticosteroid injection. I think all internists must know how to inject the bursa. Surgical debridement is rarely indicated. In fact, in my mind, never. Next slide, please. And this is what you will see. This is a shoulder X-ray, and this is the calcium deposit. Now, if you repeat this X-ray for 8 weeks, it will be gone. And this is a BCP crystal, basic calcium phosphate. No pyro, basic calcium phosphate, otherwise called hydroxyapatite. Next slide, please. A 24-year-old woman is evaluated because of a 12-hour history of fever, chills, and severe pain and swelling of the right ankle. 1 year ago, she underwent successful cadaveric renal transplantation following development of rapidly progressive glomerulonephritis. Maintenance therapy include prednisone and cyclosporin. She is sexually active. Physical examination shows an exquisitely tender and swollen right ankle. BUN is 30, creatinine is 1, that means her transplanted kidney is working. Synovial fluid obtained by arthrosynthesis, so 20,000 leukocytes, very inflamed, and then needle-shaped, negatively birefringent crystals. The positively refringent and negatively refringent is physics. I do not have the ability to explain to you why they call it negative and positive, but remember, it's the physics, it is not biology. But she has crystals and they are needle shaped and there are 20,000 leukocytes. Next slide. Which of the following most likely contributed to the development of crystals in this patient's synovial fluid? Cyclosporin, prednisone, hyperphosphatemia, hyperoxalemia, hypercalcemia. Please answer. Okay. Most of you got the correct answer, cyclosporin. Hypercalcemia, hyperoxalemia, none of them would cause this kind of acute arthritis. Prednisone, definitely not. If anything, prednisone would make it better. Cyclosporin is used in transplant medicine, and cyclosporin is one of the few causes of significant amount of hyperuricemia. There was teaching for years that drug-induced gout does not cause tophi. That's not true anymore after we started to use cyclosporin. Cyclosporin may cause even tophaceous gout, particularly if given with a diuretic. Remember, 100% of patients on cyclosporin will get hypertension of some degree because cyclosporin is a vasoconstrictor. So typically, patient also gets hydrochlorothiazide. So and hydrochlorothiazide raises uric acid also. So this patient, she's 24-year-old woman, gets gout because of cyclosporin. And very little option. You may want to change to tacrolimus or something, but there's not much you can do. You may have to use uric acid lowering agents. Next slide, please. So this is tophaceous gout, a picture on the right. I have known cases personally in my practice where patients have, this is many years ago, patient was treated with gold injections thinking that it was rheumatoid. This of course doesn't look like rheumatoid, but it can. Now there are 4 different scenarios in gout. Asymptomatic hyperuricemia, that means you do a chemistry and you find uric acid of 8. Typically, nothing needs to be done other than weight loss or any removing offending agent. Acute gout, intercritical gout. Intercritical gout is gout between 2 attacks. And then, of course, the picture on the right says chronic tophaceous gout. Next slide, please. This is acute gout. You have 2 joints involved, the podagra, the metatarsophalangeal joint, and the ankle. Typically, gout is a monoarticular disease, but you can have polyarticular gout. The drawing on the right is taken from medieval times, and gout was a terrible disease affecting people, and you can see the devil eating up your foot. I like that painting. Next slide, please. A 68-year-old man is seen for a 4-week history of severe lower leg pain, swelling, and redness. The pain is over the shin and ankles. Note the location. He was treated with a course of cephalexin, followed by clindamycin without relief. He has a history of gout and atrial fibrillation. Medications include allopurinol, colchicine, and apixaban. Vital signs are normal. Left lower shin is red, warm, and tender. The erythema is not sharply demarcated. Remember, cellulitis, there is a sharp demarcation of the redness. The left ankle is swollen, warm, and tender. So you have a left ankle swollen, red and tender, and a left lower shin. There is no skin breakdown. Tophi are present over the elbows. So he has a lot of uric acid burden. ESR is 90. Serum uric acid is 6.8, not terribly high. Blood cultures performed 1 week ago are negative. X-rays are normal. Aspiration of the left ankle yields no fluid. Next slide. Which of the following is the most appropriate next step in the management? Indomethacin, IV clindamycin, MR of the leg, prednisone, surgical debridement. Management could be diagnosis or treatment. Please answer. Okay, if somebody wants to do an MR, there's a split on prednisone and indomethacin. Can we go back to the slide? The back. Okay. Let me close this. Do you want to give indomethacin to somebody who is taking apixaban? I don't think so. It's contraindicated. So go forwards, please. Next slide. Now, the correct answer is prednisone. And if you go and, I'm sorry to make you do this, but please go back. I want to review. They already gave her 2 antibiotics. Next slide, please. They gave her no, I think one before this. Okay. They gave her 2 antibiotics. There is no point in giving IV clindamycin. What's the diagnosis? There's nothing to debride. MR of the leg is not going to help much. You're not suspecting deeper tissue problems. And the point here is this person has gout. So the question is, why does the shin, the lower leg, is involved? Next slide, please. And this is why. Gout is the only inflammation I know which transcends the joint line. So if I have a, let's say, arthritis of my wrist, it will stop at the joint line. It will not cross the joint line and go into my hand or my forearm. If I have arthritis, acute arthritis of my knee, it will not go into my leg or the thigh. Exception is gout. Gout inflammation, for some reason, transcends beyond the joint line and can inflame the skin adjoining it. And of course, when you see an inflamed skin, you would think about cellulitis. So the clue is that if the cellulitis doesn't respond to antibiotics, think about underlying gout. I've seen significant number of patients over last few years where this is missed. Next slide, please. So gout, you have strongly negative birefringent intracellular needle subcrystal. They have to be intracellular for you to make a diagnosis of acute gout. Because in the intercritical periods where there is no symptom, uric acid crystals may be present in the joint fluid. Serum uric acid level is not helpful for diagnosis. You may do it some other time for treatment, but it's not helpful. Actually, during the acute attack, the serum uric acid level goes down because of cytokines. Cytokines are uricosuric. Treatment is different for acute and chronic gout. Next slide, please. 76-year-old man seeks advice regarding dietary modification to help prevent gout flares. He recently experienced his first episode of podagra, that is the metatarsophalangeal joint. At his initial visit, serum urate level was 7.2. History is also significant for hypertension, for which he takes losartan. Physical vital signs are normal, BMI 27, remainder of the physical exam is normal. In addition to meat restriction, purines, increased intake of which of the following may help to increase the patient's risk, to decrease the patient's risk of gouty flares? Leafy green vegetables, low-fat dairy products, red wine, shellfish, and fruit juice. Please answer. Now, who can go against green vegetables? That's the wrong answer. Green vegetables have no action on uric acid levels at all. They have oxalate, but not uric acid. Red wine might even increase the uric acid level and may increase the episodes of gout. So does shellfish. And fruit juice have practically no effect on uric acid level. But dairy products do reduce uric acid. Small amount, but do reduce uric acid. And you don't want to use regular dairy because of the fat content. So the correct answer is low-fat dairy products. Next slide, please. A 55-year-old man is diagnosed with hypertension. Other than a single episode of podagra, that metatarsophalangeal joint, 6 months ago, his medical history is unremarkable. He takes no medications. His father and brother have gout. It's a highly familial disease. Blood pressure is 152/100, which is up. Rest of the vital signs are normal. BMI is 24, which is good. Remainder of the physical exam is unremarkable. BUN normal, creatinine normal, electrolyte normal, serum urate is 7.9. Which of the following they're not asking about gout, they're asking about antihypertensive drug is most appropriate for this patient? Hydrochlorothiazide, lisinopril, losartan, metoprolol. Please answer. Okay. You definitely do not want to give him hydrochlorothiazide. That will only increase his gouty episodes because hydrochlorothiazide invariably will increase the uric acid. I think you can get away with lisinopril, losartan, and metoprolol, but why not kill two birds with one stone? Losartan is uricosuric, and therefore, somebody who has a uric acid of 7.9 and you have hypertension, why not give a drug which will reduce the uric acid to a little bit lower? It's not very powerful. It's not as powerful as allopurinol, but losartan is. So if you put this patient on an increased low-fat milk diet and give him losartan, you may not have to give him allopurinol or any of the other things. That's the reason I put these two questions here. It's useful to go over this. Next slide, please. A 53-year-old man is evaluated for 5-year history of recurrent gouty attacks involving various joints. Episodes are becoming more frequent and severe. He has hypertension and chronic kidney disease stage 3. Medications include lisinopril and metoprolol. Patient is of Thai descent. Vital signs are normal. There is no tophi or swollen joints. Serum uric acid level is high, 9.2, and he is getting attacks. Which of the following is the most appropriate next step in management? Management could be diagnosis or treatment. Begin allopurinol, begin probenecid, measure ANA, order HLA-B 5801, and start low-dose prednisone. Please answer this. Okay, this is a hard question, so let's answer this quickly. I think those of you giving allopurinol might kill him. Allopurinol has a rare toxicity called Stevens-Johnson syndrome, and it occurs in patients who have this particular HLA-B 5801. HLA-B 5801 is mostly seen in people from Thailand, Han Chinese, and Pacific Rim. In America, it is about 2%. In the Chinese and Thai population, it's about 8 to 12%. So if you're going to give anybody allopurinol, and if they happen to be Chinese or Thai descent, you are absolutely obliged to check 5801. Because if they do have 5801 and you give them allopurinol, they will get Stevens-Johnson syndrome, which carries a mortality of 20%. Now, should we do this for non-Thai, non-Chinese people? I don't know, but that is a question comes up. Allopurinol is a drug which they will take rest of their lives. And you have to see one patient with Stevens-Johnson's from allopurinol, and you'll never forget it. So even though it is not recommended, I would definitely consider doing this HLA before giving allopurinol. Probenecid would be contraindicated because he has a chronic kidney disease. It's not going to work. It will throw more burden on the kidneys and make kidney disease worse. Low-dose prednisone is not a definitive treatment. Prednisone is a treatment for acute gout, but not for chronic. I think they put ANA because the fellow who wrote the question ran out of options. I don't think anybody would do. I don't think anybody did ANA here. Next slide, please. So allopurinol, what are the indications? Of course, if you have a kidney stone, uric acid, or if you have tophi, in renal insufficiency, you can use allopurinol as long as you adjust the dose. Allopurinol is traditionally given before chemotherapy, cytotoxic cytolytic therapy to prevent uric acid and the kidney failure. If the uric acid excretion is more than 1,000, for normal diet, a normal person excretes less than 600 milligrams of uric acid in the urine in 24 hours. About 1,000 is called hyperuricosuric. Between 600 and 1,000 is borderline. If you are using allopurinol and for some reason your patient needs azathioprine or 6-MP, please adjust the dose and be very careful because all three are metabolized by xanthine oxidase. Next slide, please. So gout. An increased uric acid level alone is not diagnostic of gout. A normal uric acid level there's a typo, at the time of the acute attack does not rule out gout. I told you the cytokines are uricosuric. Gout-related soft tissue inflammation can mimic cellulitis. I showed you a case. Rule out infection even when uric acid crystals have been identified. So if you tap a joint and you see crystals, you still must culture the joint fluid because infection and gout can coexist. Do not use allopurinol and azathioprine together. I told you why, xanthine oxidase. Do not prescribe colchicine in patients with renal failure. And you should be able to answer this question because colchicine accumulates and can cause a myopathy. Next slide, please. An elevated uric acid alone is not diagnostic of gout. A normal uric acid level at the time of acute attack does not rule out gout. I think we went over this. And I think I said that bacterial co-infection can occur. Next slide, please. We are going to the third crystal. We talked about BCP or calcium apatite. We talked about uric acid crystals, and now we are going to talk about CPPD, calcium pyrophosphate dihydrate. There's a pyro there. The best way I can describe CPPD disease, it's a pseudo disease. The classic disease we know is pseudo gout, but it can mimic rheumatoid arthritis. It can mimic osteoarthritis. It can cause pseudoseptic, pseudo-Charcot, a destructive joint, pseudo-rheumatic fever, and pseudo-spondylitis. So what's the learning point here? That if you are dealing with a rheumatological differential diagnosis, CPPD must be in your list because it can mimic a lot of things. Next slide, please. Once you make a diagnosis of CPPD disease by demonstrating crystals or chondrocalcinosis, you're not done. You have to look for underlying cause. Why did the person develop CPPD disease? And these are the conditions you must rule out. Hyperparathyroidism, hypothyroidism, hypomagnesemia, hypophosphatemia, hemochromatosis, Wilson's disease, and ochronosis. Now, these are not zebras. We see these things, and they will ask in the board these questions all the time. So look up hemochromatosis we discuss, Wilson's disease, the age group is different. Ochronosis is homogenesic aciduria. It affects cartilage, deposits of homogenesic acid in the cartilage and destroys the cartilage. And patients will come with osteoarthritis in a premature age. Next slide, please. This is chondrocalcinosis. You can see the, now remember that this patient may be completely asymptomatic right now. So chondrocalcinosis is a radiological finding. Pseudogout is a clinical finding. You can have chondrocalcinosis without pseudogout. You can have pseudogout without chondrocalcinosis. Next slide. These crystals are pleomorphic, different forms, and they are weakly, positively birefringent. The rule is, when I was a fellow in rheumatology, the rule is that you have to search for these crystals for half an hour. If you don't find after half an hour search, then you can say there are no crystals. Uric acid crystal, you find them in 1 minute under the microscope. So they are, because they are very weakly positively birefringent. Next slide, please. A 50-year-old farmer has intermittent migratory arthritis. We already know about 2 migratory arthritis, right? Rheumatic fever and gonococcal. This is another one. Migratory arthritis affecting his knees and other large joints for the past 3 years, big joints. For the past 6 months, he has low-grade fever, crampy abdominal pain, and 10 pounds of weight loss and diarrhea. Colonoscopy was normal. He was diagnosed to have uveitis after he complained of visual disturbance. He is on no medications. And note that he is a farmer. Physical, BMI is 21. We don't know what his BMI was before, but he has lost 10 pounds. Right eye has mild redness. Remember that he had uveitis. There is a grade 2 systolic murmur. Abdominal is diffusely tender and joints have full range of motion and no inflammation. Next slide, please. The skin is hyperpigmented in sun-exposed area. Remember, he's a farmer, so he's likely to get hyperpigmented. He's anemic. Platelets are high. Platelets are poor man's saturate. It is an acute phase reactant. ESR is high, 38, not terribly exciting, but he has a low albumin. And remember, they told you he had diarrhea also. ANA, rheumatoid factor, and ANCA are negative. PPD and urinalysis are negative. CT abdomen shows mild enlargement of the spleen and several mesenteric lymph nodes. So he has a lymphadenopathy. Which of the following tests is most likely, once again, to confirm the diagnosis? A bone marrow biopsy with cultures, repeat colonoscopy with blind biopsies, synovial fluid analysis during next flare-up, small bowel biopsy, and PET scan. Answer the question, please. Okay. Many of you answered the question correctly. Small bowel biopsy. This is Whipple's disease. Now, Whipple's disease, the clue is his occupation. He's a farmer. People who work with soil, the organism Treponema whippeli, it's an infectious disease. Treponema whippeli live in the soil. So epidemiologically speaking, it's more common in people who work with soil, including farmers. And the manifestations is migratory arthritis or arthralgias, mostly involving large joint. It does not affect the small joints of the hands typically. The other clue is he is hyperpigmented. Even though you can explain his hyperpigmentation because he is a farmer, Whipple's disease does cause hyperpigmentation. And his main manifestation is in the GI tract, but it affects his small bowel. So colonoscopy is not going to do anything for you. He needs a small bowel study. It can affect central nervous system, may even cause dementia. It can cause endocarditis. He has a grade 2 murmur, so that's something to be looked at. And the diagnostic test is small bowel biopsy, where you will see PAS positive cells. You can do a PCR for the organism, and the treatment is long course of antibiotics. And you can give almost any antibiotics, doxycycline, macrolides, rifampin, even chloromycetin. If there is a CNS involvement, they want you to give intravenous ceftriaxone followed by Bactrim. Please look up the treatment protocols. They're pretty extensive. Whipple's disease does appear in the boards almost all the time. Next slide, please. A 54 man is evaluated 1 month history of back pain and lower leg swelling during the past 2 weeks. He has the goiter removed 5 years ago. He takes thyroxine. Vital signs are normal. There's a 2+ lower limb edema. He is anemic. Creatinine is up, 2.1. Normal urinalysis. Ultrasound shows bilateral hydronephrosis. Non-contrast CT shows soft tissue mass around the infrarenal aorta without lymphadenopathy. The ureters are encased within the mass. Which of the following is the most likely diagnosis? Germ cell tumor, IgG4 disease, lymphoma, peritoneal mesothelioma. Okay, there's nothing to suggest that he has a mesothelioma. I think the clue is in the goiter. He has a goiter, which was probably Riedel struma, you remember from medical school days. This is an IgG4 related disease, IgG4 related disease, which affects any part of the body from head to toes. The eyes, lacrimal glands cause macular disease, dry eyes, mimics Sjogren syndrome. It can affect the lungs, it can affect the thyroid, of course, and mostly intra-abdominal. It causes a tumor. It's called tumification, tumor formation, which would close the ureters and cause hydronephrosis and renal failure. It responds to steroids very quickly. It also affects the pancreas, and that is called autoimmune pancreatitis. This is a favorite topic for the boards recently. Next slide, please. We are going to move to the final 45 minutes or so of what is called sports medicine, what I call soft tissue rheumatism. Next slide, please. I want to remind you, because to understand the soft tissue rheumatism, you need to remind yourself about the anatomy of the joint. Of course, there are bones, then there's a cartilage. So cartilage is the osteoarthritis. Then there is a synovial membrane, synovial lining. The synovial lining, if it's inflamed, causes synovitis, rheumatoid arthritis, lupus, etc. Of course, a joint cannot move if there is no muscle. So there is a muscle, so you can get myositis, myopathies. The muscle cannot insert into the bone. It becomes a tendon, and then the tendon inserts into the bone. The site of insertion is called enthesis. And there are 600 muscles in the body, so there must be 600 entheses. And the entheses can get inflamed. The hallmark of spondyloarthritis is enthesitis. We discussed this. Tendon get inflamed, tendonitis or tendinopathy. I think we talked about fluoroquinolones giving you tendinopathy. You have a capsule and ligaments, they can get inflamed. Your bursae, bursaes are sacs of liquid, gelatinous liquid, to reduce friction between the moving parts. So any of these conditions can get inflamed, can break, can degenerate, or can get infected. So how do we determine which one is that? So let's go to the next slide. In a generic form, most of the musculoskeletal problems, the sports medicine type, are overuse syndrome. That means a repetitive motion of a particular body part resulting in micro trauma of the musculotendinous unit. So the treatment has to be reducing movement of the part. So rest is the important part. Now you're dealing with athletes and you tell them to rest, they will get upset with you. But you have to do that. Because giving them, I think we did some questions where the young woman was running and they wanted you to give naproxen. No, that is not the treatment. You need to remove the underlying cause. So treatment includes rest of the affected part along with a progressive exercise. Remember they said quads and hamstrings? That's what it is. NSAIDs have limited value, particularly if there's a contraindication, and you must avoid narcotics. Many athletes get addicted to Percocets and things like that. And you may inject locally a corticosteroid. Next slide, please. So let's talk about decurvain tenosynovitis. I told you about the osteoarthritis of the base of the thumb, the first carpometacarpal joint. So that would hurt at the base of the thumb. The differential diagnosis is inflammation of the tendons of the extensor pollicis brevis and the abductor pollicis longus. Fancy name, but the basic English is short and the long tendon of the thumb. Basically, that's what it is. There are two tendons going into the thumb. One is long, other is short. And if that gets inflamed, you will have a pain in the base of the thumb, and you may have difficulty diagnosing which one it is because the treatments are different and the outcomes are different. So what we do to distinguish, we do what is called a Finkelstein test. You take your palm, I don't know whether you can see me, you put your palm, your thumb into the palm, close the hand, patience, and then you, as a doctor, just move this and stretch these tendons. And the patient will jump. That is decurvain tenosynovitis. You inject. If you know how to inject, you can inject, or you can send them to a sports medicine doctor and give them a splint. It works. For the carpometacarpal joint, there is no good treatment. Next slide, please. So tenosynovitis of those two tendons, typically due to repetitive injury and pain on the radial side of the wrist, And most common misdiagnosis is osteoarthritis of the first CM joint. And I told you about the Finkelstein test. Next slide. In a positive Finkelstein test, pain increases when the thumb is folded across the palm and the fingers are flexed over the thumb as the examiner passively deviates the wrist towards the ulnar side. Treatment is local heat, NSAIDs, immobilization, local steroid injection, very rarely surgery. Next slide. Diabetic chiroarthropathy. This used to be a very favorite exam questions. I can bet you that if you go on the wards and you see 10 diabetics, you will see this complication. It's insidious and progressive. It is considered to be a microvascular complication, just like neuropathy, retinopathy, or renal involvement. And the clue is positive prayer sign. Next slide.
Dr. Kothari, you have some questions in the chat.
Okay. So let me see. Do I go to the chat or the question answer?
To the chat.
Okay.
One is asking you to demonstrate on your hands a bit higher.
Okay. Oh yes, I'm sorry. This is the patient's hand, and the patient puts the thumb inside and closes the fist. You, as a doctor, will then take the hand and move it ulnar side. You're stretching. Just do it yourself right now. You will feel the tension on the tendons, and if the tendon is inflamed, the patient will tell you that, and that is the Finkelstein test. In the CM joint osteoarthritis, that will not occur. You can do this, they will not have pain. Most of them are technical. I don't think.
That's correct. It's Finkelstein's test positive in OA.
Okay, this is the diabetic chiroarthropathy. If you do a prayer, do it now, and you will see no gap between your hands. Should not be. If you have it, then you're in trouble. This is the patient with diabetic chiroarthropathy, and you look at the gap between the two hands. And that is a microvascular complication of diabetes. Totally inexpensive, don't have to do anything, just ask the patient to fold the hand and see if there is any space. So what's the mechanism? What's the pathogenesis? The pathogenesis is there is a sclerosis of the skin and the subcutaneous tissues. So let's say you wear a glove of size 8 and you use a glove 7.5. Your hand will not be straight, it will bend. Exactly, the skin is 7.5, hand is 8 here. That's why they have a gap between it's very similar to scleroderma. So this is a simple test, do at the bedside, and you'll be amazed how many. In the original description, it was suggested that only type 1 gets it, but actually that's not true. I see more in type 2. The other features of diabetes in the hand includes Dupuytren's contractures. You all know that. So look for Dupuytren's contracture in the hand, and the trick is to do transverse, not this way. If there are knots, you will find it by doing transverse. Next slide, please. Here's a patient with numbness of the, I have never met a patient who told me that he has a numbness in 3.5 fingers. They typically say, my hand is numb. And you push them, then they will tell you maybe these 2 fingers. But 3.5 is in median nerve distribution. The important point to remember, can we go to the next slide, please? It's the most common entrapment neuropathy. And the number of causes, any connective tissue disease, rheumatoid, lupus can do that. Occupational injury, that was a big thing once upon a time, but it is now taking backseat. Diabetes itself can give you a neuropathy, which includes carpal tunnel, hypothyroidism, acromegaly, pregnancy, and dialysis. If they may give you a pregnant woman with carpal tunnel syndrome, do not send her for surgery. Wait till the pregnancy is over. We talked about dialysis related carpal tunnel because of better to microglobin deposits into the carpal tunnel. You get paresthesias of the 3.5 fingers. The key point clinical to remember is that the numbness goes down, but it also goes up all the way to the cubital fossa or even higher. Therefore, many times is mistaken for a radiculopathy coming from the cervical spine. So be careful. Next slide, please. If you examine carefully, you will find diminished sensation over the median nerve distribution, and you know where the median nerve is. Thenar muscle strength is decreased or atrophy. Diagnosis is clinical. You do not need to do electrodiagnostic studies. And they treat the underlying cause. If you find it, most likely you're not going to find it. You can do a splint. You can give corticosteroid injection. In US, we don't do that for some reason. In Europe, that is standard treatment. If necessary, you can give NSAIDs, and as a last resort, you can do surgery. If you stop the overuse, most likely you will not need surgery. Next, please. This is a splint. You can buy it in any pharmacy. And we recommend that the people wear at night, because remember, carpal tunnel syndrome, the symptoms are worse when you flex the wrist. Because when you flex the wrist, the carpal tunnel becomes smaller. When you extend the wrist, carpal tunnel becomes larger. So years ago, we used to give an extension splint, but it's not necessary. Just a neutral splint is all you need. And when we sleep, we are flexed. Everything is flexed. Therefore, the symptoms occur during night. When you're on telephone, your knee wrist is flexed. Therefore, symptoms occur when you are talking on phone, etc. Next slide, please. Let us go to Anserin bursa. Just little anatomy. The word Anserin, it means goose foot. Pes is foot. Anserin is goose. And I have a picture on the left, which is a goose foot. There are 3 tendons, sartorius, gracilis, and semitendinosus. They all become a conjoined tendon. It's a huge tendon with big muscles. And to protect from a lot of friction, there is a bursa seated here, right here. It's on the medial side of your knee, about 1.5 inches below the joint line. You need to locate that site. There is no fat there, even in fat people. So that's where the bursa is. Extremely common. Next slide, please. Is composed of conjoined tendons of sartorius, gracilis, and semitendinosus, seen in middle-aged and elderly overweight women, and they may have concomitant osteoarthritis, and most commonly it is mistaken for osteoarthritis. You have to be very careful in examination. Osteoarthritis should give you diffuse pain. Bursitis give you localized pain. I've known cases where, because of chronic pain of the knee due to bursitis and also concomitant osteoarthritis, the surgeons have replaced the knee, and bursitis still remains. Pain and tenderness over the medial aspect of the knee, about 1.5 to 2 inches below the joint margin. And pain worsens on climbing, and the treatment is local corticosteroid injection, depot preparation of corticosteroid. And you give them a lidocaine and corticosteroid injection, instantly the patient will have relief because of the lidocaine. Remember that whenever you inject corticosteroid in bursa or joints, there is a steroid flare-up. Steroids are crystals, so the body reacts as a foreign body and may be flare-up. So you tell your patients that you may have worse pain tomorrow and cover them with ibuprofen or something for 24 hours, and then they will have the steroid effect and will benefit. Next slide, please. A 26-year-old woman is evaluated for lateral knee pain and distal thigh of 6 weeks duration. She's a runner. The pain is worse when she runs downhill. She has no trauma and no report of catching, grinding, or locking. In other words, she does not have meniscus injury. Vital signs are normal. Tenderness is noted 2 centimeters proximal to the lateral femoral condyle. Remember, the anterior medial, this is lateral. With patient supine, pain is reproduced with repeated flexion and extension of the knee as the thumb pressure is applied to the lateral femoral condyle. There is no joint line tenderness, effusion, ligamentous laxity when applied stress. So young runner with lateral pain. Now, just to recap, anterior pain is patellofemoral. Medial pain is medial meniscus and anterior bursa. This is lateral. Next slide. Which of the following is the most likely diagnosis? Iliotibial bend syndrome, lateral collateral ligament tear, lateral meniscus tear, meralgia parastatica. Answer, please. Excellent. Almost everyone got it, so we don't need to discuss it. This is iliotibial bend syndrome. I do not know I have a slide on this. Can you please go to the next slide? No. The iliotibial band goes from pelvis all the way to the tibia. It is a lateral. So, and typically occurs in runners. The treatment is the same as before. I told you, cut down the running, small doses of NSAIDs, etc. Let us go to the olecranon bursa, very favorite question. There are two types of questions. One is plain olecranon bursitis, other is septic olecranon bursitis. Typically occurs with friction when somebody like me sitting on the chair and constantly rubbing the elbow. It can occur with gout and rheumatoid arthritis, and for some reason, patients with uremia on hemodialysis may get that. The important thing to remember is an extra articular problem. Therefore, the joint has no problem moving. So range of motion of the elbow is normal. If it is red and warm, you must aspirate and make sure that there is no infection. That is olecranon bursitis. Next slide, please. Prepatellar bursitis. I told you anterior knee pain would be patella, patellofemoral thing, and this is the next one. It's also called housemaid's knee because years ago when women used to be on their knees cleaning the floor, the bursa which sits on top of the patella, as you can see in this picture, that gets inflamed, swollen, and tender. And because the bursa is just under the skin. And right now we are not seeing this because women typically do not do this, but we do see in certain occupations, for example, in carpet layers, people who put the carpet in the rooms, they may get that. They're on their knees, they use the big knee pads to protect themselves. Treatment is same. Reduce the activity, and you may give NSAIDs or you may give a steroid injection. Next slide, please. A 78-year-old moderately obese woman is evaluated about a night hip pain that worsens when she goes up and down the stairs. She says she cannot sleep on her right side because of pain over the hip. Now remember, I told you the definition of a hip for a lay person is gluteal region typically. For you and me, is a groin. She has been active and good health. Physical exam, moving the right hip to rotation, flexion, extension does not elicit pain. But abduction, abduction reproduces the pain minimally. There is tenderness to pressure over the lateral aspect of the right hip. So we have two physical findings. Abduction causes some pain, and there's tenderness over the lateral aspect of the right hip. Which of the following is the best next step in patient's management? Once again, management could be diagnosis or treatment. Order X-ray of the right hip, prescribe NSAID, inject painful spot with steroid, refer the patient for physical therapy, advise the patient to use hot packs in an area for 20 minutes, 3 times daily. Next slide, please. Okay, this is a very widespread opinion. The correct answer is injecting this is trochanteric bursitis. This is not a hip disease, so the X-ray of the hip is not going to be of much value. This is, you can give NSAIDs, but look at the stent. Which of the following is the best next step? So NSAIDs would not, and why give NSAIDs for a 1-inch problem? Refer the patient for physical therapy. Completely useless. Hot packs, my grandmother would have done that. I don't think that is any therapeutic advantage. The correct answer is load up your syringe with 1 ml of lidocaine, 1%, and 20 to 40 milligrams of depomedrol. Mix it up infiltrate the area, the tender area in a circle, and the patient will be instantly relieved of the pain. Next slide, please. So trochanteric bursitis, just to remind you, the greater trochanter is here. That is the outermost part of your thigh. And big muscles are inserted into the greater trochanter, and that can get inflamed. Next slide, please. Typically occurs in middle-aged or elderly women. Why more common in women, we don't know. Maybe because of fat distribution. Aching over the trochanteric area of the lateral thigh. It can go down to the knee. Walking and laying on the affected side increases the pain. Therefore, they cannot sleep at night because they cannot lay on that side. And the most common misdiagnosis is radiculopathy, because if it migrates to the knee, then immediately they diagnose radiculopathy. The clue is you find the greater trochanter, ask the patient to be in decubitus position on the table, find the greater trochanter and press on it. They will jump. Take a syringe, load it up with steroid and lidocaine and inject. Patient will go out without pain. Once again, cover them for a flare-up because steroids might cause more pain next day. Next slide, please. A 38-year-old school teacher is referred to you for evaluation of left lateral hip pain. Note this side. She describes a persistent burning sensation over the outer thigh and has been present for 6 weeks. Neither direct pressure to the area nor hip or lower back movement influences this localized area of pain. On exam, there is a full range of motion of the hips and lumbar spine. There is no focal area of tenderness on palpation of the lower back or pelvic region. Sensory examination reveals that pinprick and light touch are abnormal in 10 by 6 centimeter oval area over the anterolateral surface of the thigh. Note the site. The straight leg raising test is negative, and deep tendon reflexes and distal motor strengths are preserved. Next slide, please. You suspect the diagnosis is myalgia paresthetica, left-sided lumbar disc herniation, trochanteric bursitis, complex regional pain syndrome, ischial bursitis. Please answer. Okay, this is terrific. Almost everyone got it. This is classic myalgia paresthetica. And can you go back to the slide, please? Okay, the clue is here. Persistent burning sensation. Burning means neuropathy. Always. There's no exception as far as I can tell. Burning means neuropathy. And then the physical examination shows the sensory deficit. So this is compression of the lateral cutaneous nerve of the thigh, typically due to obesity. They didn't give you that here. Next slide, please. So we already discussed trochanteric bursitis. Disc herniation, the pain radiates into the thigh but crosses the knee. If it doesn't cross the knee, it is not a radiculopathy. Complex regional pain syndrome is a disease which gives you significant amount of lancinating neuropathic pain after a trivial trauma. We don't have time to discuss this. Ischial bursitis, I don't know why they put it in. The ischium is way far away from where the problem is. So ischial bursitis is not. This is myalgia paresthetica. Treatment is weight loss. End of, next slide, please. A 47-year-old man is evaluated for burning pain, another burning pain in the lateral thigh that began insidiously and has persisted for several weeks. The pain increases on standing and walking, decreases on sitting or laying down, but has otherwise remained constant for 5 weeks. He has no other pain, weakness, or trauma. He has been able to perform his job as a taxi driver without limitations. Except for the pain in his leg, he feels well. His history is significant only for obesity. He takes no medications, no allergies, and denies cigarettes, alcohol, or illicit drugs. He has gained 20 pounds in past 6 months. On physical exam, patient is large, middle-aged man with no acute distress. Blood pressure is normal, pulse is normal. Right hip and knee have full active and passive range of motion without pain. Motor strength of all muscle group is 5/5. Knee and ankle stretch reflexes are 2+, equal in both legs. Patient has a area of hypoesthesia along the right anterior lateral thigh above the knee. He can feel a monofilament when it touches the bottom of his feet. The rest of the sensory examination is normal. Pulses are 2+. Look at the size of this question. Pulses are 2+ and equal. Next slide, please. Results of lab studies done 2 months ago, A1C level of 4 and a fasting glucose of 89. They're telling you in numerous ways that he doesn't have diabetic neuropathy. Which of the following is most appropriate next diagnostic test? Plain X-rays of the lumbar spine, no further testing, vitamin B12 levels, magnetic resonance imaging of the lumbar spine, and nerve conduction studies. Answer, please. Okay, I think most of you got it. In boards, if they give an option of known further testing, typically that is the correct answer. But here we have a diagnosis of myalgia parasitica. This guy is overweight, he has gained 20 pounds, he drives a taxi, so he sits. So he presses his nerves all over. And no further testing is necessary. The treatment is going to be weight loss. For the past 6 months, a 52-year-old woman has noted recurrent moderately severe pain and tenderness in the region of the right elbow. Pain occurs mainly with the use of arm and hand. She has noted no pain or tenderness in other joints. She has felt weak generally. She has felt well generally, except for some occasional fatigue. Right elbow shows marked tenderness near the distal end of the lateral aspect of the humerus. I'm showing you on my arm. Range of motion is normal. There is no tenderness of swelling. Resisted wrist extension. That means you ask the patient to extend the wrist and you put your hand and not allow to extend. Exacerbates the elbow pain. Which of the following tests would most likely provide the diagnosis? Rheumatoid factor, anti-nuclear antibody, sedimentation rate, radiograph for the elbow, and no further testing is necessary. Please answer. Okay, everybody got that. This is a clinical diagnosis of tennis elbow or lateral epicondylitis. Please move to the next slide. This is the anatomy of the elbow. You have a lateral epicondyle. You can feel it on your body. You have extensor muscles. That's why when you resist the extension, you are making these muscles active. These are the extensor muscles, all of them, all down in red. And that presses on the tendon, and that causes inflammation and pain. The treatment, once again, is removing any offending agent. If they are doing some exercise, lifting weights. It is called tennis elbow, but about 90% of the people never have seen a tennis racket. So they love their diagnosis that they have tennis elbow, a yuppie disease, but it can occur with carrying a briefcase, for example. But you must remove the offending agent. Do not inject a tendon, ever. Leave it to the orthopods. Please do not inject a tendon because remember, corticosteroids are catabolic. If you inject a tendon, you will weaken the tendon and the tendon may rupture. So it's an overuse syndrome. It's a localized tenderness directly over the lateral epicondyle. It's diagnostic. You don't need a test. And pain may occur during a handshake or lifting a briefcase. It's very disabling when it happens. So you need to know the diagnosis. And the opposite, the medial epicondyle, if you have the same thing, is due to flexor muscles. And that is called golfer's elbow, but it is very similar both ways. Next slide, please. So how do you treat? Epicondylitis, the golfer's elbow involves the flexor muscles, and you have exactly the same thing, but on the other side. Next slide, please. Plantar fasciitis, a very favorite question, very common in the practice. I just want to remind you about the plantar fascia. It attaches to the calcaneum, the tubercle, and then it divides into and goes into the toes. It stabilizes the arch. It's a pain on the plantar aspect of the heel, on weight bearing and tenderness on palpation. So when this get up in it, because there is some element of inflammation, it typically occurs after a period of rest. So first thing in the morning, when they put the foot down, they have a lot of pain. Please remember that it is associated with spondyloarthritis. We talked about this last week. And the management includes NSAIDs, use of heel cups, orthosis, arch support, and local injection. I would favor local injection of corticosteroid, and that's all you need. But all these overuse syndromes take time. Next slide, please. Achilles tendinopathy. Achilles tendon is the biggest tendon in the body and is likely to get involved and can rupture and cause a lot of disabilities. The most common cause of Achilles tendonitis is overuse. So if you decide to go and hike a mountain, you may come home with Achilles tendinopathy. Improper shoes, another cause. Anything with the legs, lower extremities, always check the shoes. You'll be amazed to see the wear and tear at the bottom, so different between left and right. Gout can cause gouty tophi there and can cause inflammation, rheumatoid arthritis, calcium pyrophosphate disease. But the most common one should know is overuse and spondyloarthropathy. You have tenderness and pain over the insertion of the tendon right here. So my favorite question is, what is the commonest cause of heel pain? Depends. If it is the back of the heel, it is tendo-Achilles. If it's the bottom of the heel, it's plantar fasciitis. And you can do some dorsiflexion and you may feel a crepitus. Treatment is same, correct the shoes. One simple thing can change the outcome. If you put a shoe lift under the sole, that means your foot is elevated, very similar to wearing high heel shoe. The pain instantly will diminish because the tendon is relaxed. So a simple thing is to get a wedge, and it's available in $5 in pharmacies. And you insert the wedge, it's about 1/4 of an inch or even less than that, maybe a few millimeters. It's a triangular thing. You insert in there so your heel is slightly elevated, and that usually takes care of it. Do not inject steroids in the tendon. Next slide, please. This is, you see the feet from behind, and you have to examine the patient standing up from behind. The picture on the right is normal. There's some concavity here, but here is all diffusely swollen. That is tendo-Achilles. You don't see this all the time, but sometimes you do see it. Next slide, please. The last segment we are coming is rotator cuff. We already talked about the rupture of the rotator cuff in Milwaukee shoulder. Next slide, please. Rotator cuff tendonitis, it's a large group of muscles, and it can be acute or chronic, and pain with active abduction, 60 to 120 degrees. I don't know whether you can see me, but it doesn't hurt up to 60 degrees. And then it hurts and up to 120 degrees. Abduction. You can see calcium deposits. I showed you a picture, and that calcium will go away. It is calcium hydroxyapatite or BCP. The other thing, less pain is present on passive abduction than active abduction. That's not important point clinically. I think just the reproduction of pain on 90 degrees is all you need. The treatment, the favorite treatment is local corticosteroid. And we should all know how to inject this. It's very simple. You don't even need an ultrasound. You take some steroid, you take some lidocaine, and immediately. The important thing about anything with shoulder is make sure they don't immobilize the shoulder. It used to be custom among the orthopedic surgeons, when you go with a shoulder pain of any kind, they'll give you a triangular splint. Basically, they're immobilizing the shoulder. If you immobilize the shoulder, you're likely to develop reflex sympathetic dystrophy. You never immobilize the shoulder. In fact, After injecting it, you must tell the patient to exercise his shoulder. So what exercise do? They stand up. I don't know whether you can see me. And they put the arm down and they make circles with the shoulder. And they make bigger and bigger circles. They do it for about 2 minutes every day. The second exercise, they stand near a wall and they, with fingers, they climb the wall all the way. I tell them that you must achieve the Statue of Liberty position once a day. That will prevent any immobilization, because not only you get shoulder reflex sympathetic dystrophy, but you also get a frozen shoulder. Frozen shoulder is a horrific complication of any immobilization. I don't know any one of you are old enough to remember this, but one of the complications of acute myocardial infarction was frozen shoulder. Because acute myocardial infarction, when I was a resident, acute myocardial infarction required 4 weeks of bed rest. The patients are afraid to move. They ended up with a frozen shoulder, reflex sympathetic dystrophy, and a disaster. I think this is such an important topic, the tendonitis, that we should all know this and we should know how to inject the shoulder. Next slide. I think we are done more or less. Rotator cuff tear. This is important. We talked about inflammation. Now we are talking about tear. As many as 50% of patients with rotator cuff tear have no history of trauma. They say, I don't know why I got the tear, particularly elderly. They have shoulder pain and weakness on abduction. They cannot do 90-degree abduction. If you ask them to keep this, the arm will drop. That's called drop arm test. They cannot actively maintain 90 degrees. Normal abduction does not rule out a tear. You have to do an MRI. If you are concerned about a tear, MRI is the only answer. Maybe an ultrasound in the future. Maybe some people do ultrasound now. The other thing to remember is that in the elderly patient, you do not need to do surgery. You can just watch them, because surgery can cause a lot of other issues.
Do you have a slide to show where to inject the shoulder?
Yes, it is. I don't have a shoulder picture here. Okay, I think that would do. This is your shoulder. You go down and you need to know anatomy where the bursa is. And typically it happens to be the most tender point of the bursitis. You find the spot and you don't inject, you infiltrate. That's the difference. Inject means you put in a needle and you push the material, but you want to give it in a circle, like this circle. So you insert the needle. There's nothing there for you to hurt at all. There's no structure which you can damage. But you need to select this site properly. And then you go around with the needle and then slowly squirt the mixture of lidocaine and corticosteroid into that area. You will know immediately whether it was the right place, because the patient will have resolution of pain right away because of lidocaine. But don't forget to tell them that the pain will come back when the lidocaine wears off, and may even increase the pain because of more inflammation from the crystals of steroids. Steroid is a crystalline stuff. So therefore, you must give them something to cover for the next 24 to 48 hours, ibuprofen if not contraindicated. And steroids will take effect after 24 hours, and then they are fine. Make sure you tell them to exercise what I showed you. That's important. Okay, let me go back to the chat if there's anybody. I think somebody had a, please post any comments, okay? Would you please demonstrate with hands? I did that. Finkelstein test we saw. Plantar stretching, I'm glad you reminded me. Plantar stretching is very effective, and thank you for reminding me for that. And plantar stretching ideally should be done by you lie down, the patient lies down, and somebody stretches the ankle, dorsiflexes it and releases it. But they can do themselves by putting a towel around the foot and then bringing it up and down. It works, definitely. Thank you. I think John did this. Thank you, John.
You're welcome.
Let me see.
I believe you have
They
everything.
all praise for me. Thank you. But okay, I think thank you. Thank you all for your attention and good comments. Appreciate that. But we are going to make this course very successful. On behalf of the ACP, I want to thank you. And I hope you will join us in our next session.